everybody. Just quick Instagram, Facebook, check. I'm getting live video notifications. Excellent. Hello, everybody, and welcome to the PT on Ice Daily Show. My name is Christina Previtt. I am one of two lead faculty for the modern management of the older adult geriatric curriculum. We have 3 courses that we teach in the curriculum for CERT MMOA. That is our 8-week online essential foundations, where our next cohort is starting June 23rd, and we are already over 50% sold out for that cohort. So if you're looking to get in some geriatric content this summer, I would encourage you to sign up. We have our advanced concepts course, which is for individuals who have taken the 8-week online essential foundations. And our next cohort is starting in October. We only do that cohort 2 to 3 times a year because you have to have taken essential foundations to come into advanced concepts. And then we are just finishing up a major overhaul for our live course. And so we are really excited to be bringing a lot of new, fresh content based on the literature over the last several years to your clinic or to you live in person. I'm going to tell you, if I look a little flustered and sweaty, that is because I just had to chase a chicken that got out of her run today right before I jumped onto this call, and a shepherd decided that she wanted to try and help me. So there is never a dull moment on the Previtt homestead, which is barely a homestead. It's very small, but we have chickens. And so if I look a little sweaty, I'm going to apologize in advance. Because this 7-month pregnant individual was chasing after chickens this morning. Okay, so the motivation behind today's post, we're going to start talking about busting myths around arthritis. We had a longtime listener to the podcast email us and say, hey, I noticed that you haven't done a ton of arthritis content. And I was reflecting on that, thinking we must have. Arthritis is such a huge deal in geriatric care. And when I was looking back, we definitely did a lot at the very beginning when the geriatric content came onto PT on Ice, but it has been a long time since we've done a lot of episodes around arthritis. So I thought that we would try and do some of that today. If you are working with older adults, if you're working with anyone really over the age of 40, you are dealing with arthritis in some way, shape, or form, whether it be the reason for referral or the reason for some pain that may increase levels of sedentary behavior and subsequent deconditioning or changes in physical function. And therefore, it's something that we really do have to stay on top of the literature. I think there's a very common thought in arthritis management that nothing really changes in arthritis. And that's not really true, especially in terms of surgical management and joint replacement research. There's been a lot that's been done in terms of the pathophysiology as well as some of the changes to surgical management for joint replacements that I think are really relevant for PTs. And as well, we're really starting to get a good idea around how the optimal dosage of exercise can really be beneficial for individuals with arthritis. And there's been a lot more evidence in lower extremity joints, with the hip and knee being the most common, but we're starting to see some rehab trials come out for individuals who have had shoulder replacements or ankle replacements as they start to become more commonly done by surgeons, as well as are able to be rehabbed by clinicians. I'm sorry, my dog is barking. Alrighty, so a little bit of a momentary interlude. Okay, so in terms of the 6 common myths that we're going to talk about in arthritis care. So number 1 is osteoarthritis is only wear and tear on the joint. And that is completely untrue. We have literature to support that there is an inflammatory cascade that happens that contributes to pathology. And some of the literature that has been done to support that hypothesis has been around obesity management and inflammatory loads in non-weight-bearing joints. So the common thought process is that if an individual has a higher BMI, they are putting more stress along their hips and knee joints, and that can contribute to accelerated degradation of joint space, which is true. But what we also see is that individuals who have a higher BMI, which we know increases the amount of pro-inflammatory cytokines within the bloodstream, are also seeing accelerated arthritis, osteoarthritis in the joints of the hands, in particular the CMC joints. And that doesn't really go with the hypothesis that it's the extra weight placing additional load on the joint. And we had to look for a different option as to why this was happening. And so we saw this link between the level of pro-inflammatory cytokines that is circulating throughout a woman or a man's body and the link between degradation in joints that are non-weight bearing. Obviously, there is a bigger effect in those load-bearing joints. However, we are seeing it in peripheral joints as well. So it leads to some support for that diagnosis, which means that just like we're trying to see with the inflammatory arthritis, where we're talking a lot about health promotion and lifestyle management, we should be doing the exact same thing when it comes to load-bearing joints in osteoarthritis as well. All right, myth number 2, knee replacements are inevitable / knee replacements are not needed. So I think this absolute language is really detrimental, and it's commonly talked about with our patients. Some of our patients believe that either they have to have a joint replacement or that everything that we do with conservative management can 100% prevent the need for a joint replacement, and neither of these absolutes are true. We know that trying to have increased uptake of healthy lifestyle factors is going to prolong the lifespan of a joint without need for intervention. We also know that strength and conservative management can significantly improve function and pain from arthritis, but we also know that joint replacements, and in particular, especially with the literature in hip and knee replacements, that we can see a significant increase in quality of life and reduction in pain, which translates into an increase in function once that pain has gotten to a particular level. And so what we need to do, and sometimes one of the hardest conversations we have when we talk about this in our geriatrics courses is, when do you give up on conservative care? And when do you say, okay, it's probably time for you to consider getting that joint replacement? And that's not an easy question, right? It's nuanced, and we often take the subjective and objective assessment data. We see how much the pain from arthritis, despite a good, sometimes they say 6 months to a year. We don't have strict clinical guidelines on that. Despite a good effort, 6 to 12 months in conservative management hasn't changed their physical function or optimized their pain in enough of a manner that is going to lead to an increase in quality of life, or the quality of life that a person wants based on where they're at in their life. And so once you kind of have all of that data, and you really do feel like you've tried and that your client has tried, then it's probably time to refer on to an orthopedic surgeon. And you know that all of the work that you rehab in order for them to come back more resilient post-surgery. Myth number 3 is that the image is irrelevant. This is something really common that's going around a lot of different things, and it's absolutely true that we cannot use an X-ray as the number one and only determining factor for function when it comes to arthritis. But to tell a client that the fact that you have bone-on-bone arthritis means absolutely nothing is incorrect, and can sometimes come off as very dismissive of a very real complaint. And so we need to be a little bit cautious about our communication. And I've done PT on Ice episodes about this before, where we do have literature to say that the correlation between the joint space and degree of pain is blurry. But everything in rehab is blurry, and we can never, ever look at one outcome measure, modality, subjective complaint, or question to describe the true spectrum that is musculoskeletal pain. And so that would be very reductionist. But what we do know is that when individuals do serial X-rays over time, those that have demonstrated an increase in pain over time are also more likely to show a reduction in joint space over time as well. And what that means is that the joint space narrowing is contributing to pathology, right? We we would never say that a person has arthritis and arthritis is linked to pain if they have a normal joint space. So there is something going on from a pathology perspective. And while I love the idea of empowering clients that, just because there is a reduction in joint space intervention, we need to be cautious to not be dismissive of the x-ray, because it is giving us valuable information. It's just one piece of the puzzle, and there are many things that can contribute to pain, function, and quality of life for individuals who are living with arthritis. Number 4 is you can't kneel after a knee replacement. We just posted about this on the PT on Ice, the Ice Physio Instagram and Facebook pages, and we had so much wonderful engagement on that post where we had conversations around then why is my surgeon telling my clients that they can't kneel, which is a wonderful question. And they talk about how pain can be a limiting factor. And it really speaks to the fact that we need to be prioritizing kneeling once we have sufficient healing of the incision as well as range of motion within the joint to support a kneeling position, to start looking at some of those persistent pain, scar desensitization, and graded exposure to kneeling post knee replacement. We have no evidence to support that there's going to be any dislodging of the prosthetic or any sort of negative ramification of kneeling post knee replacement. It was a conservative recommendation that is now no longer supported by the literature, and the inability to kneel is a very, very pertinent piece of the puzzle for a person's quality of life, because things like being able to get onto the floor to clean up a mess, to be able to play with your grandkids, to be able to take part in religious ceremonies, to be able to recover from falls is all extremely important. And we don't want that fear of exposure to kneeling to be a barrier for individuals exploring movement in whatever facet or fashion that they want to. And the inability to kneel post knee replacement is one of the biggest causes of dissatisfaction with knee replacement. And in my mind, that is a physio goal. And so that is a PT goal, and it should be something that is on us to try and optimize their function in order for them to be able to tolerate kneeling. All right, that is number 4. Number 5 is that hyaluric acid is beneficial. This might be a little bit of a controversy. Some people use things like Synvisc injections, and there's a lot of different commercial names for basically trying to reuse synovial fluid or put synovial fluid back in the joint. From the literature that I have looked at, and to be honest, I haven't looked at this in over a year, there seems to be like 50-50 spread across the literature, with 50% of trials saying that it's beneficial and 50% of trials saying that it isn't, which makes me believe that there's a strong placebo effect going on, and it might not be the first course of action for, in particular, knee osteoarthritis. I've had some clients who have, I would never dismiss if that was what the surgeon or the family physician or GP suggested in an attempt to not break therapeutic alliance or create this cognitive dissonance in my client. But if they were asking me, I would say that, sometimes the evidence on it is pretty wishy-washy, and it depends, because there's a lot of insurance companies that don't cover this. And I think part of the reason for that is because the data on the efficacy of that type of injection is fairly inconclusive. All right, number 6, my final myth busting about arthritis is that hip precautions reduce hip dislocations and are beneficial. And we are seeing time and time again across multiple systematic reviews, across multiple types of approaches for hip replacements, that the need for hip precautions is very obsolete. And what we need to be really thinking about is gradually moving into those positions while we are respecting the client's pain and irritability. And therefore, by the time they are able to really cross midline or have their hip flex below parallel, they have probably done a sufficient amount of healing, that the hip precautions themselves, especially because there's many times where they're not discharged soon enough, can actually create a fear of movement and a sensitivity across those ranges that are really, really important for physical function. And so we want to make sure, again, that we're not instilling this fear of movement, especially post-surgery for joint replacements, in individuals who we already know are fairly persistent in that persistent pain loop from, however many years of dealing with pain from arthritis in whatever joint that you are working with them with. And so those are kind of just our thoughts. And I've done a PT on ice that really debunks the hip precautions literature. Again, I know that is a very, very sensitive and sometimes challenging subject, because what we end up doing is we're potentially going against the surgeon's recommendations. And so there's a lot of advocacy that we still need to do. But now we have 3 systematic reviews with progressively bigger sample sizes, a number of studies included, that have looked at anterior, anterolateral, and posterior approaches with the same conclusions. All right, that is my common myths. So number 1, OA is only wear and tear. It is absolutely not. There is an inflammatory cascade that happens in osteoarthritis as well. Number 2, knee replacement is inevitable. Knee replacements are not ever going to be needed. Both of those are absolute language that we can never guarantee, and both may be incorrect. Number 3, the image is irrelevant. That has some merit, but it's more nuanced than that, and we can't make that very reductionist statement. Number 4, you can't kneel after a knee replacement. That is absolutely not true. We have no evidence to support that it's going to dislodge the prosthetic, or that it's going to increase wear and tear or decrease the life of the joint replacement, and therefore we should be trying to encourage kneeling and desensitizing into that position with our clients. Number 5, hyaluric acid is beneficial. Right now the literature is not very conclusive on that. And number 6, hip precautions reduce hip dislocations. We do not have any evidence to support that is true, and gradually increasing range of motion, respecting a person's pain and irritability, is likely the way to go. All right, I hope you all enjoyed that episode. I'm so sorry for the flustered beginning and the dog barking in the middle. That is just, unfortunately, my country life. If you have any questions about the topics that we talked about today, or you're looking for any of the data, let me know. You can message me on Instagram at Christina_Prevett. Thank you so much. That's really kind of you. And I can get that to you. Sometimes if you tag ICE, we have so much stuff that's going on. I don't always see it. So if you respond and comment on ICE and I don't get back to you, just please tag me personally so that I can make sure that I get all of that data to you. All right. Have a wonderful Wednesday. The next time you're going to see me is next Tuesday, where I'm going to tackle statistics. I'm really sorry about that, but I think it's really important. And we will see you all next week.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.